Hello, and welcome to the APAC Recap. I am Erin Pardee, a physician associate and board member for the Academy of Physician Associates in Cardiology, or APAC. I am joined today by Viet, a fellow board member and PA, and we're going to discuss a recent conference that he attended, the American Society of Preventive Cardiology, Congress on Cardiovascular Disease Prevention. Can you tell us a little bit about the conference, Viet?
Yeah, thank you, Erin. So ASPC, the American Society of Preventive Cardiology, has their annual meeting. And this is one of, it's quickly become my favorite meeting because it's so pragmatic in the space of preventive cardiology. This year was held in Salt Lake City, my hometown. And it's a 2.5-day conference where there are 13 sessions. And, look forward in the future. There are currently no late-breaking clinical trials that are presented at the conference, but that is in the works for the future. I don't know if I should have said that, but that'll put some pressure on my partners there to do so. I was on the planning committee, and so was able to help bring together the topics for this conference. So I'm highly engaged with the committee and with this organization because it is my home. It covers the depth and breadth of preventive cardiology, including things we wouldn't typically consider traditional cardiology topics like obesity, like metabolic disease. But you probably recently heard about the American Heart Association Presidential Advisory on Cardio, Kidney, Metabolic Health. And so what that really tells you is that most everything rolls up to a sequelae of cardiovascular disease. And so, how do we prevent that? So this is a conference that covers those items in I think, a very pragmatic fashion. It's fun because you see the speakers and faculty members across all of the other conferences where they're speaking mainly on a science basis. There's a lot of bench science. Here at this conference, we actually have a lot of give and take, a lot of discussion. And I feel like folks let that down their hair, so to speak. I can't, but they do.
Wow, that's great. That is certainly a new and evolving field, and new data is always coming out. So I agree, having late-breaking trials would be really beneficial. What was one of your favorite presentations, and did you learn anything that would change your practice?
Yeah, I think for me, one of my favorite sessions, of course, of any session is a debate session where you get to hear your colleagues and experts in the field really present a topic and then do pros and cons on it. In this case, there were discussions on using colchicine versus just strictly aggressive lipid lowering. There was a discussion on using CT, coronary angiogram or coronary calcium, in terms of refining risk for folks, and really was CAC versus CTA. And then finally, a discussion on whether or not we should be looking at, and is it actionable to order lipoprotein A or LP(a), a newer to most folks actually, apolipoprotein that well defines risk, but what do we do with it?
Right? Yeah, there have been recent recommendations where they say it's a good screening tool for everyone, but then once you have that data and the patient in front of you, but there's not a medication you can use, and who are you going to do electrophoresis on? What are you going to do with that information?
Yeah. No, I mean, and that was part of that debate. Is it ready to go? Is it prime time for primary prevention? So let me just add my thoughts on that. I think we're here at a debate talking about coronary calcium and CT angiogram, but you can't really target coronary calcium, but it's a risk factor. So what do you use it for? You use it to nuance the intensity of your therapies. So LP(a) is very similar to that. We know what it does. It is very similar to LDL cholesterol in that it creates plaque. It can get behind the endothelium, and also it has thrombogenesis. And so knowing these things in your patient might well improve your intensity of risk modification for other things like diabetes, like hypertension, like smoking. But it might also speak to the threshold of LDL cholesterol lowering, whereas you might just go less than 70 on some. Here, if they have an elevated Lp(a), you may target their LDL cholesterol level to less than 55. So it's, to me, it is prime time. And by the way, full disclosure, I'm a sub-investigator at Intermountain for 2 different Lp(a) lowering phase 3 trials. And so we have a lot of excitement in this space, but we'll see. We'll see if lowering it actually leads to reduction in events.
Wow. Yeah, that's really wonderful. So is there a certain patient population that you do recommend general cardiology practitioners to order this test on?
Yeah, so I think, following the National Lipid Association, there are others. I actually prefer that it just be drawn in everyone at least once. But if you find that a patient has been referred to you in general cardiology, you're the right group to get an Lp(a) at least once, because typically, if someone's worried about cardiovascular complications or risk. In particular, the folks that seem to puzzle us most are those that have very few other risk factors, but have an event in their 30s or 40s. And so I would argue I wouldn't argue, but I would submit to folks that an Lp(a) is very similar in risk as having familial hypercholesterolemia, a mutation of LDL cholesterol. So yeah, anyone that comes through your door in a general cardiology clinic should get an Lp(a). It is informative as to what to do, and it is informative to that patient and their family as to risk for the next generation, because it's fairly highly heritable. It's autosomal dominant, so 50% chance of inheriting it. If mom or dad has it, then the 4 kids, 2 of them will probably have an elevated Lp(a). Wow.
That is very interesting, and that is some great information that I think all of our providers can benefit from. So what type of specialty or provider would benefit from going to this conference, and do they have something set up for next year?
Yeah, so this is an ongoing, now it's a well-established organization with plans for annual conferences. It'll probably be in the same time frame, either early August or mid-August of every year. But who should attend? I really think if you have any patient with a heart, you should attend ASPC at least once. You really should, because preventive cardiology, again, encompasses all of us. So let me just tell you, the topics that we talked about encompass heart failure, your area of arrhythmia. We talked about structural heart issues. And then, of course, people think of preventive cardiology as lipids and hypertension. Yeah, that's part of it. But there's a growing expansion of knowledge and expansive knowledge over, the metabolic realm as well. And so all of these are risk factors across the subspecialty areas of cardiology. So at least once folks should attend. And I think you'll be hooked because the group is really inviting. It's currently small, but they've increased by almost 100% over the last 2 years, from 200 to 400 members. And it'll grow because of all the different wonderful therapies and modalities. If you have never used an SGLT2 or GLP-1 or a non-steroidal MRA or colchicine, it's a great place to get learned up. It's magnetic.
Yeah. Wonderful. That sounds really great. Did they offer CME?
Yes. So the CME, this is across the entire 2.5 days. For the life of me, I can't remember the exact CME. I believe it's up to 20 credits, though, that are available. And that they have credits for PharmDs and nurse practitioners as well. And I believe a lot of this is set for high pharmacology credits for our nurse practitioner colleagues.
Great. Do you discover any good clinician resources?
Yeah, so at the website itself, and mainly this is for members, there are, behind the firewall, I guess, or the paywall, is a bunch of resources that are available for clinicians that are quite pragmatic, help you to figure out, SGLT2 prescription and management, what to tell the patient, what to look for, etc. But because we come from so many different areas of cardiology, including National Lipid Association and ACC, AHA, much of the education content can be linked back to those organizations. So the website for ASPC is aspconline.org. If you're looking for the conference, it is www.aspconline.org/2024 Congress. You'll find that they do have readily available education pieces for providers and their patients.
Great. That is always helpful when you're seeing patients to have a resource that you can quickly check and confirm you have the right plan. What was your favorite aspect of the conference?
I think for me, you will not believe me. I am introverted in the sense that I have a hard time in a room where I don't know people. I just don't meet people easily. But these are members of my community, and I've seen them at, I meet them at ACC, AJ, ESC. Although I've not been to ESC, these are the same folks that attend those conferences. And so to come to ASPC, that's where it's really nice for me, because we talk on a pragmatic level and patient scenarios. We're discussing therapies on a clinic level. We're like, okay, that's great. I heard the SELECT trial. That's great. I heard the Oceanic AF trial. But what does it mean? And so we talk about how that actually gets implemented on a patient-per-patient level. So that's my favorite part of really each of these sessions, is it's designed to say, what will you do, Viet? What will you do for your patients on Monday after this conference ends on Sunday? What are the things that you can implement immediately? And that's what I love about this conference.
Yeah, and it's really nice living in this post-COVID world where we can all get together at conferences and collaborate. So speaking of conferences in person, I wanted to let everybody know about our conference that we have upcoming. So it's called CAP, and it is in October 17th to 19th in Red Rocks, Las Vegas. That's this year, 2024. We're offering a wide range of cardiology topics, from valves to coronary syndrome, electrophysiology, cardiomyopathy, lipids, heart failure, POTS, and cardiac devices. Our speakers will cover the most up-to-date guidelines, best practices, and things not to miss as a cardiology provider. We hope to see you all there. If you want to learn more, you can go to our website, APAC website, or CAP, CAPP Live.
Oh, thank you so much, Erin, for bringing up CAP, and that's Cardiovascular Advanced Practice Providers. I am excited about this conference. A little biased. I have a couple of sessions that I'll be presenting at, and I hope you do come, because we'll talk about navigating hyperlipidemia, and some of the things that I've spoken of today will include metabolic dysfunction. And so I will talk about MASH and MASLD, and then finally we'll review the chest pain guidelines and how that the applicability of the things that we learned from the inaugural chest pain guideline, and how that'll affect your practice both in the acute and stable after you visit with patients from an acute coronary syndrome event. But again, MASH and MASLD, those are newer terms that we've learned, but metabolic associated dysfunction.
It's going to be so great, Viet. We're really looking forward to listening to your talks. This has been an episode of the ACAP Recap. Thanks for listening. You can find this episode and more at our website, HCP Live, and on YouTube.